kill this. Alright. You only got one copy.
Yeah. I can make another.
No, that's fine.
Sure. Or I can take the staples out.
Oh,
It's for mother.
I'm gonna log in on my iPad just so I can keep an eye on it.
Did you already hit record?
It automatically is recording.
Okay.
Yep. Uh-oh. My printer died.
Hello, everyone. I'm Amy Sauer. I'm one of Patrick's P4 students, and today I'll be talking about Chapter 2 from the NICU Primer for Pharmacists, Developmental Pharmacology, Pharmacokinetics, and Pharmacodynamics. So first, I'm just going to refresh everyone on ADME. These properties are going to develop as the neonates progress in age, and they're much different than that of adults or pediatric patients. Absorption is how medication gets into the body and the bloodstream. Distribution is where the medication goes after it's in the body and the bloodstream. Metabolism is going to be what happens to the medication once it's inside the body. And then elimination is how the parent medication or drug and metabolites leave the body. Absorption with enteral forms. So factors affecting this are going to be function of brush border enzymes in neonates, decreased intestinal surface area, varying pancreatic enzyme activity and biliary function, and shorter gut transit time. The gastric pH lowers during the first 48 hours of life from neutral pH at birth. And then during the first week, pH is going to become more neutral and then decrease over the first 2 years of life to the adult pH. And these pH changes are going to affect bioavailability. Neonates are going to have prolonged gastric emptying and reduced intestinal motility. For intramuscular forms, absorption is unpredictable and it's not usually recommended. This leads to a possible reduction in absorption due to the decreased skeletal muscle blood flow or less muscle contraction, or it could lead to an increased absorption, possibly from the capillary dense muscle. Percutaneous forms are going to have an increased risk of systemic exposure in neonates because of the larger body to surface area mass ratio, and epidermis absorbs moisture very well. And there's also better perfusion to the cutaneous layer. Preterm infants also have thinner skin, which can affect absorption of percutaneous forms. So topical forms should be used with caution. As far as rectal forms, neonates have rectal contractions that pulsate, and so this can lead to frequent evacuation of the medication and can limit absorption. Factors that affect distribution are lipophilicity and hydrophilicity, patient body composition, protein or tissue binding. Total body water is 85% in preterm neonates compared to 75% in term neonates. Just for reference, adult total body water is about 50 to 60%, so it's higher in the neonate population. So hydrophilic medications are going to have a larger volume of distribution and therefore is going to concentrate in the tissues. And because of this, weight-based dosing is very important. An example of this would be with aminoglycosides in younger patients. Gentamicin doses are going to be 4.5 to 5 milligrams per kilogram per dose for preterm neonates compared to about 4 milligrams per kilogram per dose for term neonates. Total body fat of preterm neonates is 1 to 2% compared to 10 to 15% in term neonates. So lipophilic medications are likely to concentrate in the plasma. And this is due to the smaller volume of distribution. Plasma protein concentrations and protein binding affinities for medications are reduced in neonates. An example of this is phenytoin and benzodiazepines, and they have an increased volume of distribution in neonates since they have a decreased number of the plasma binding proteins and decreased affinity of medications. Circulating competitive binding protein bound compounds are increased in neonates, affecting medications that bind to albumin. So some of these medications are ceftriaxone and sulfonamides, and they're going to compete with the bilirubin for albumin binding sites, and they can increase your risk of kernicterus, which is where bilirubin moves into the brain and can cause brain damage. Metabolism is broken into phase 1 and phase 2. Phase 1 is going to increase hydrophilicity, and phase 2 is going to conjugate parent medication or metabolite. Metabolism via the CYP450 enzymes typically reaches adult levels at 1 year of age. So here are some of the different enzymes for metabolism and how they're different in neonates. So CYP3A7 is significantly expressed through the 6 months of age, and then it becomes more CYP3A4, and that's going to increase with postnatal age. An example of this is preterm neonates that have decreased clearance of midazolam compared to term neonates. For CYP1A2, there's decreased enzymatic activity, and this is going to affect metabolism of methylxanthine, which is going to increase its half-life in neonates. CYP2C9, 30% of mature activity is born at the third semester. There's 30% of mature activity if they're born at the third trimester, and it's going to increase during the first 5 months of age to adult levels. And a drug that's affected by this is phenytoin. For CYP2C19, the activity at birth is 15% of the adult levels, and it's going to reach the adult levels at 10 years of age. An example of some drugs that use this metabolism is benzodiazepines and proton pump inhibitors. CYP2D6 is limited during the first year of life, and UGT is also decreased in neonates. For elimination, factors that are going to affect that are smaller tubular size, reduced blood flow, urine pH variation, and limited concentration abilities in neonates. Each process for renal elimination, which is glomerular filtration, tubular excretion, tubular reabsorption, is going to mature at a different rate. Glomerular filtration significantly is increased by 6 months of age, and tubular function increases over the first year of life. Complete renal function approximates adult function around 1 year of age. So since there are many pharmacologic, pharmacokinetic, and pharmacodynamic differences in neonates, fulfilling orders closely is very important when you're verifying or preparing their medications. Here are my references, and thank you for listening.